Hi, my name is Shreyas Joshi. This is my presentation about my objective to reduce the prostate cancer death rate, which is part of the Healthy People 2020 objectives list. Um, the desired improvement that I uh, hope to achieve with these interventions is to reduce the rate of prostate cancer deaths from what its current state is, as measured in 2007, which is about 24 prostate cancer deaths per 100,000, to a desired improvement, which is about 21.8 deaths per 100,000. That represents about a 10% improvement over the baseline. There are multiple steps that I think that are necessary to realize this goal. Number one is that we need to improve the behavioral health of men in later life to reduce all-cause mortality. We also need to improve community-level healthcare engagement with at-risk African American populations and expand social marketing campaigns to target these at-risk populations with the overarching goal, which is, as I will argue, that a reduction in the African American prostate cancer mortality rate will affect, or at least make a significant dent in this 10% decrease that we want in the overall prostate cancer mortality rate. Some of the history of this is, and the significance of prostate cancer mortality, is that it's the second leading cause of cancer-related death in American men. There has been a steady decline in prostate cancer mortality over several decades, and this was due, as I'll show later, to the introduction of PSA screening in 1992 that really put a dent in prostate cancer mortality. Since the early 1990s, there's been nearly a 45% decrease in prostate cancer mortality in the United States. And you can actually see this. This is a graph taken from the SEER, which is a Surveillance Epidemiology and End Results Program from the National Cancer Institute, showing that around the early 1990s, there was a dramatic drop in later stage prostate cancers being detected. So this was a fantastic positive direction for prostate cancer mortality to take. Unfortunately, there is a little bit of controversy involved, and this is regarding the USPSTF, which is the United States Preventive Services Task Force, which is granted authority under the Affordable Care Act for making some of these guidelines. In 2012, they gave a recommendation grade of a D, which recommended against routine PSA screening in average man, potentially exacerbating the burden of disease on at-risk populations. What they argued was that the risk of treatment outweigh the risk of the disease, and that is certainly true if you're over-treating prostate cancer. Unfortunately, African men are disproportionately affected by prostate cancer mortality, and they also have less screening and access to healthcare engagement, which puts them at a significantly more vulnerable position. Of the estimated 23.1 million African American men, only about 39% reported undergoing PSA screening in their lifetimes, which is actually kind of low given the prevalence of prostate cancer in elderly African American men. About 44 states had lower rates of prostate cancer screening in black men ages 55 to 69. Again, very problematic given the higher rates of prostate cancer incidence and mortality in African American men. So I'll go through some of those numbers. In 2015, there were about 221,000 new cases diagnosed and 27,000 deaths, which is why it's the second leading cause of cancer-related death in men. The death rate is not evenly distributed. African American men have about 37 deaths per 100,000, which is quite a bit different than the national average, which is 24 deaths per 100,000. And in Asian Americans, it's actually down to 6 deaths per 100,000. So there's a wide disparity. The incidence itself of prostate cancer diagnosis is also uneven. This is taken from SEER data. In Caucasians, 112 per 100,000. Hispanics are a little bit lower than that, and African American men are much higher, 190 per 100,000. This is another graph that I think is illustrative, taken from the SEER database. The top line indicates the number of prostate cancers that are found at a localized or regional state, which is very good because those are very treatable prostate cancers. It's this lower line that has distant or unstaged prostate cancers that is driving all of that mortality. And I think with appropriate screening and treatment and engagement, this population can be more effectively managed. So some of the research findings that support the points that I'll be making in my paper. There are socioeconomic forces at play. This article that I think was very good, published in 2006 by Du, studied the SEER database of a population-based cohort of over 61,000 men in the 1990s. They found a direct linear correlation between decreasing socioeconomic status and risk of prostate cancer mortality. And in their multivariate analysis, they did use other factors that one would assume would also be associated with that mortality rate, including race, which they didn't find was necessarily an independent factor, but it did point to a large socioeconomic reason that prostate cancer mortality exists above and beyond biologically based factors. There are a few points that I'd like to make here. One is that there are large socioeconomic racial disparities, and so even though race was not an independent factor in the specific study, there are pockets, especially around the United States, especially in large urban centers where minorities have lower socioeconomic status, and that fuels a lot of their healthcare outcomes, especially because in the current environment, talking about healthcare or talking about healthcare insurance, socioeconomic forces are a strong driver in whether or not a patient or person is going to be insured and will get the care that they need or the screening that they need. And then lastly, there's this cultural and historic reason that African American men are less likely to seek medical care, and one can just think of the Tuskegee experiments and the history in the United States to know why that's the case. And so there are a lot of theories and interventions to try and turn this around, but I think that all plays into prostate cancer mortality as well. Secondly, I'll argue that there's a behavioral risk that affects all-cause mortality and that needs to be addressed in order to reduce prostate cancer mortality. Cancer mortality itself, as I mentioned, shouldn't be viewed in a vacuum, especially with treatable cancers such as prostate cancer. Behavioral risk factors will affect long-term survival. And so I'll argue that culturally appropriate interventions should be tailored to these at-risk populations to help improve their overall health, especially later in life. This is a great paper in 2016 by Lee. It looked at it was funded by the CDC, looking at the behavioral risk factor surveillance system of over 8,000 men with a history of prostate cancer. They found that there was a significant difference between Black and Caucasian prostate cancer survivors with multiple behavioral factors such as alcohol consumption, obesity, or the receipt of the pneumococcal vaccine, which is a good indicator of whether or not they're getting their primary healthcare needs met. They concluded, as I mentioned, that culturally appropriate interventions are necessary to help reduce the survival disparity between these demographics. And lastly, screening guidelines need to be updated or more carefully refined, I think, in order to help delineate which populations are at risk and should be managed more aggressively than others. So they should reflect risk categorization, and African American men, are disproportionately affected by recommendations against the use of prostate cancer or against the use of PSA testing. This Shenoy article in 2016 looked at a kind of large meta-analysis of the risk factors that African American men have, and they argued that these guidelines will disproportionately harm African American men. They looked at a variety of biological, environmental, and social causes for the disparity in prostate cancer outcomes. And they argue in a very effective manner that because this demographic is 2 to 3 times more likely to die of prostate cancer, there should be a more nuanced recommendation rather than a blanket recommendation against prostate cancer screening with PSA testing, especially in the African American population and at-risk population, which would include men that have urinary symptoms or that have a strong family history of prostate cancer. To kind of give you a glimpse of what we fear in the urologic world about the USPSTF guidelines is looking at this tail of distant stage prostate cancers that has this uptick after the USPSTF guidelines in 2012, demonstrating that we may be about to see a lot more deaths rather than it going down. So there are several ethical issues at play here. One is justice. I think justice is a major moral principle that's violated by any disproportionate cancer mortality. Inequality in healthcare delivery violates fundamental medical and public health norms of practice. And I think the USPSTF guidelines border on violating this principle. There's the ethical principle of beneficence, so engagement to improve health behavior, screening practices, and healthcare interactions. They're all done with a good faith goal in mind of decreasing prostate cancer mortality. And engagement, however, should be targeted to those who will receive the greatest benefit. What that means is that increase engagement with those who are at risk, but don't unnecessarily screen or treat those who are at low risk and expose them to the harms of treatment. And lastly, autonomy is another ethical principle at play here. People need to be provided with the necessary resources and information to make the best medical decisions for themselves, and they should then be granted the opportunity and the individual capacity to choose the best healthcare decisions that will make for healthier lives for themselves. So the next steps that I would argue are that federal and state governments need to take action to make cancer screening more equitable. Screening guidelines should take individual risk factors into account so that they don't disproportionately affect one segment of the population. Steps should be taken to identify at-risk populations, especially of African American men, to improve information dissemination and outreach based on socioeconomic and access to care realities, and that we should expand social marketing efforts such as Movember to target at-risk men. And if you're not familiar with Movember, it's this funny, gimmicky sort of campaign that's actually quite effective, that in the month of November, men grow facial hair and these terrible mustaches in order to increase the discussion of men's health and men's health related issues. Their stated goal is to reduce prostate cancer mortality by 25% by the year 2030. They do this using a multi-tier marketing, social marketing campaign. They, encourage men to grow facial hair, then do fundraisers based off of that. And they fund research and treatments, as well as funding information dissemination to improve screening practices. It's a easy website to access and gets a lot of information for men once they're directed here. And it's a one-stop portal for getting them information that otherwise they might not have been privy to. So in conclusion, prostate cancer mortality is declining, but the mortality itself is unevenly distributed among racial demographics. Screening interventions have proven to be effective, but controversy exists regarding the appropriate use of PSA screening, and that needs to be clarified, which researchers are certainly doing, but more nuance needs to be placed on at-risk populations. Specific interventions have already been identified that can improve outcomes in the most at-risk and vulnerable populations, including behavioral interventions in later life. And improved engagement with at-risk populations, and specifically African American populations, because we saw how high their mortality rates are with prostate cancer, can improve prostate cancer outcomes overall and reduce the national mortality rate as prescribed by Healthy People 2020. Here are some select references that I used in this presentation, and thank you very much for your attention.